All right. Looks like it's time to get started here. Good afternoon, everybody, and thank you for joining us today for this very special webinar. We appreciate your flexibility in attending webinars this summer outside of our typical schedule. And like all things during COVID-19, many of us have had to adapt to changes and challenges. This webinar will be recorded for future viewing. And before I introduce our guest speaker, I do have one update I would like to go over and a few other housekeeping items. It's hospital inventory time. So many of you are familiar with this annual process, and for those of you who are not, don't worry, it's pretty straightforward. The hospital inventory is a requirement by the Minnesota Department of Health, and then de-identified results are shared with CDC. The survey itself aims to capture information on acute stroke treatment capabilities and practices among hospitals in and around Minnesota, and furthermore to help identify gaps and opportunities for improvement. This year, the survey will be emailed directly to your hospital's coordinators and can be completed electronically. You should receive an email in the next few days, and please reach out directly to Mimi if you have any questions regarding the survey. As far as some housekeeping items, your lines have been muted upon entry, and we kindly ask that you keep yourself muted until the end of the presentation. At that time, we'll open the floor up for questions. However, it's always an option during the webinar to type your questions directly into the chat. To do so, click on the chat button, make sure to select everyone, type in your question, and then hit enter. At the end of the presentation, we'll do our best to get through questions as time allows. And make sure to open your chat during the Q&A session as well, as we'll place the link to the survey directly into the chat box. And we're offering a 0.5 contact hour certificate for attending today's webinar. And for those of you watching the recording, we're going to keep the survey open for a while too, so you'll be able to claim those credits after the fact. So with that said, I am delighted to introduce Dr. Ganesh Asathambi. Dr. Asathambi is a stroke neurologist and serves as the medical director of the United Hospital Comprehensive Stroke Center. In addition, he serves as chair of the Department of Neurosciences at United Hospital. He collaborates with other specialists in the community to strengthen the quality of stroke care provided to Minnesotans. He completed his training at the Universities of Missouri, Kansas City, Minnesota, and Florida, and before starting at United Hospital 6 years ago. Currently, he resides with his family in St. Paul. Ganesh, the floor is all yours.
Thanks, Nikki, and thanks to the MDH for inviting me to have this opportunity to speak to all of you. I'm eager to have a discussion at the end of this presentation. So we'll get started. Nothing relevant to disclose for this talk. The objectives for the next 20 or so minutes, we'll be reviewing strategies for acute stroke care during the COVID-19 pandemic, discuss pathophysiologic mechanisms of COVID-19 infection and stroke, and then identify methods in the acute treatment and prevention of stroke during the COVID-19 pandemic. So first, a bit of background. Over the past several months, we have been provided with several articles from a variety of locations, not only in the United States, but across the world, in a variety of journals, talking about incidents and the development of stroke among those hospitalized with COVID or presenting with stroke as or having stroke as a presenting symptom of COVID, but based on quite a bit of literature, there is some estimate of about 0.8 to 6% of hospitalized COVID-19 patients who develop stroke, and that includes both ischemic and hemorrhagic. However, the incidence varies based on methodological differences in the demography. So, of course, if we're studying an urban population, many of the patients may have different demographics than a rural-based setting or the population in another country. The current data suggests that most COVID-19 positive patients develop stroke in advanced stages of the viral illness. And it's approximated that 3 weeks from the COVID-19 diagnosis is when stroke is being diagnosed. If we recall from the original SARS in the early part of 2000s, stroke was associated with SARS Part 1 in about 2.4% of patients, and this was a report from Singapore, and was found 2 to 3 weeks after being critically ill or in advanced stages of SARS. Early on, when the pandemic hit and was much more of a terror for all of us at the beginning of 2020, we did have guidelines for stroke care during the pandemic, and it was published in many journals that we refer to on a regular basis. And if you notice on the bottom part of my slide, on the bottom left, you'll notice that I do have references, but I also signify whether these references that talk about guidance or guidelines were either were approved by a professional society or institution, or whether they weren't. And so these are just general topics or recommendations which make sense in order to protect our patients as well as our healthcare providers that are helping take care of these patients. So for stroke codes, even during the pandemic, pre-notification if possible, just like outside of the pandemic, minimizing the number of staff in the emergency department to minimize exposure, potential exposure risk. So involving an emergency department physician or provider, the appropriate nursing staff and other instrumental staff such as phlebotomists and radiation technologists, and if needed, respiratory therapists, making sure everyone is wearing or donning appropriate PPE, keeping a mask on the patients as they roll in, implementing telemedicine even at your hub site if you're capable of doing it, and expecting that anticipated door-to-needle times may be delayed as we are taking the appropriate precautions to minimize risk of exposure or spread of COVID. In terms of caring for patients who receive intravenous alteplase thrombolytic therapy, there are considerations for admitting these patients to intermediate care units to save ICU beds for COVID patients. Monitoring can be performed virtually with two-way video conferencing in some cases, and when transfers are necessary, screen for COVID at spoke sites. And consider post-thrombolytic care at spoke sites rather than following a drip and ship paradigm, getting those patients to hub sites. Keep in mind, these are, again, recommendations not approved by a professional society or institution. In terms of endovascular management, patients who meet criteria eligibility for endovascular treatment, every patient must be handled as suspected COVID-19 or presumed positive until ruled out. Every post-thrombectomy patient should undergo COVID-19 testing if available during their admission. Again, anticipated door-to-puncture times may be delayed. There is an increased potential for the use of general anesthesia for concurrent infection with COVID and ischemic stroke. We can consider CT chest during the acute evaluation for those of high predictive probability of COVID-19, and for those intubated, extubating those patients in negative pressure rooms. Stroke care in select cases for those presenting with TIAs or lacunar strokes that are not disabling, we could consider sparing the hospital admission to save beds, and consider not transferring massive hemorrhagic or ischemic strokes that have a very low likelihood of a good outcome. This has been a conversation that we've had not only within our own community, but across the country, across the world, which is the impact of the pandemic on seeking stroke care and even MI care, cardiovascular care. There's quite a few articles that demonstrate the reduction in seeking care. The reference that I'm using actually looked at a database of hospitals globally and involved thousands of patients, which is why I'm showing the statistics from this paper rather than smaller studies that are in the literature. So when comparing June to May of this year and comparing it to January to May of this year and comparing it to January to May of last year, there was an approximately 43% decrease in the total number of stroke patients that were admitted. There was approximately 50% decrease in intravenous alteplase administration as a result of presenting later to the emergency department. And there was a 39% decrease in thrombectomy. And while that decrease was numerically reduced, it wasn't statistically significant, given our broad window of being able to treat patients with endovascular treatment. This is just a graphical representation of that data. You'll notice that here is January to May of last year, and then January to May of this year. And the number of patients administered intravenous alteplase was cut basically in half. And also, when comparing it to immediately before the pandemic, there was still a reduction in intravenous alteplase administration. So, attack of COVID-19. So, we know that the primary organ that coronavirus will attack is the lung. The theorized approach to how coronavirus is affecting us is through the angiotensin converting enzyme 2, which is a receptor for host entry of the virus. This is found primarily within the surface or on the surface of lung alveolar epithelial cells, venous and arterial endothelial cells, which can lead to a vasculitic type of or vasculopathy, which can result in cerebrovascular complications, arterial smooth muscle cells, and enterocytes of the small intestine. ACE2 could also be found in the cardiorespiratory neurons in the brainstem, hypothalamus, and motor cortex. The way coronavirus works, it can infect lymphocytes, monocytes, and lymphoid tissue, and this can drive the thromboinflammatory alterations that could influence stroke pathophysiology. This hyperinflammation can also drive key stroke risk factors such as atherosclerosis and atrial fibrillation. In terms of linking COVID-19 with stroke, we have been alarmed by many case reports, case series talking about the co-infection of COVID-19 with stroke, but there's really no direct evidence for that causal link between the two. We need to rely in the future, or currently, with standardized case reporting and meeting strict epidemiologic criteria in order to prove that causality between COVID-19 and stroke. We may learn more of that direct link when the vaccine is deployed, hopefully sooner than later. As many as 25% of all infected individuals may have undetected inflammation and may be at risk of thrombotic complications, which may be those younger patients with stroke that don't come in with their COVID symptoms, which is why we see so many of those case reports or case series of younger patients that present with thrombotic complications like stroke, because they may have a undetected form of inflammation related to the infection. And the incidence of stroke truly could be confounded by underreporting. For the super severe sick patients with COVID-19, there is a competing risk of mortality in which we don't undergo diagnostic testing for stroke before they pass away from the COVID-19 itself. And milder infections and strokes, for that matter, may not present to the hospital or seek care at primary care because of the fear of being exposed to the infection. Prothrombotic features of COVID-19, there were a couple reports in the New England Journal of Medicine that looked at the presence of prolonged PTT that may suggest a clotting problem. In a minority of those cases, patients did have positivity with lupus anticoagulant, and in one case series, that led to one case of a venous occlusion. There weren't any arterial cases, but that shouldn't make us ignore the clotting problems that may occur with the infection. However, it's important, again, to think about whether the infection and the hyperinflammation associated with it independently causes a clotting problem, or if it's a part of the development of DIC that occurs in patients who are very sick with COVID-19. In another series of patients who passed away from complications of COVID, autopsies were performed looking at the brain specifically, and it only showed hypoxic changes associated with respiratory illnesses from COVID and chronic atherosclerosis. There was no evidence for acute stroke, whether it was ischemic or hemorrhagic. There was also no evidence for encephalitic or other brain changes referable to the virus, suggesting that the virus doesn't necessarily cross the blood-brain barrier among infected patients. So currently, the acute treatment should still follow what we did pre-pandemic, which is don't deviate from current treatment paradigms, considering intravenous alteplase among those who are eligible, treating those endovascularly with thrombectomy among those who are eligible. And there's no clear evidence that anticoagulation is superior to antiplatelet therapy, referring to many other sites who have been epicenters of the pandemic. There have been variations in those prevention strategies. Patients presenting with large vessel occlusions had been routinely treated with anticoagulation, but we don't know the long-term outcomes of those patients or the duration of anticoagulation. We don't know that being placed on antiplatelet therapy predisposes them to inferior prevention in comparison to anticoagulation. And also, we still don't understand the mechanisms through which patients infected with COVID develop or experience hemorrhagic strokes as opposed to ischemic strokes. And so putting them on anticoagulation, could that in theory increase their potential risk of bleeding in the brain or elsewhere? And so I know we can go on, and wanted to make sure that I had an opportunity for questions. But in terms of concluding this talk, we need to follow the guidelines that are set for screening as directed by the WHO and CDC. I think when we first were presented with information about a potential link between COVID and stroke, there are many questions in terms of should we be checking every single stroke patient for COVID upon presentation. However, I think the common causes for stroke are still the common causes for stroke. That causal link between COVID and stroke needs to still be determined. And I think the big community responsibility we have is making sure that we still get that word out to still seek care, that we are all prepared to take care of those with and without COVID. So I know we could definitely talk more about all of the stuff because there's quite a bit of information about COVID and stroke, but I just wanted to get the main points out there. And I wanted to leave everyone, I think, during this Q&A session with a poem that Dr. Biller had written. I just thought it was a nice poem to read about in terms of the neurologic issues associated with COVID. But I'll have this up while people kind of talk or ask questions if there are any.
Great, thanks so much, Ganesh. For those of you that want to ask questions, please, you can unmute your lines by pressing *6 and ask your questions verbally, or you can also type them directly into the chat. Just make sure to send to everyone and press enter in order to send that question forward.
Well, I'll start off with the question then. If anyone from, whether it be Nikki or Al or anyone else from MDH, what are some questions that you guys have been receiving from stroke-ready hospitals in terms of how to organize stroke care during this time? And yes, the slides will be available. It's recorded for you to access later.
Hey, this is Nikki. I'll respond to your question there, Ganesh. I think initially, of course, back in March, we had quite a few questions, and we did send out quite a bit of communication for hospitals to work specifically with their telestroke partners and comprehensive stroke centers to be prepared for some of the things that you talked about, specifically when the suggested guidelines came out about COVID-19 and stroke care, being prepared to admit patients locally. And, not just those that are stroke patients for hospitals that end up transferring everything, but also to be prepared to admit IV alcohol patients. So I think that was the big key thing that happened at the beginning of the pandemic. We also hosted, Melissa Fries from St. Cloud also presented a webinar as well on post-alteplase care. So that was one thing that we had a lot of questions about. How do we prepare to even begin to monitor these patients at our hospitals? And so we made sure to provide that information too. But I think those were the main pieces, is if we are expected to admit, how do we even approach this?
Sure. I know within our own experiences, within our own telemedicine program, our telemedicine partners have done a wonderful job in helping accommodate kind of the amended processes to ensure that both patients and the healthcare team are properly or kept safe, basically, to minimize exposure or spread. And the care being provided has been exceptional. And we were worried about, in a way, of efficiency, but you could barely notice that it's slowing down. So I think everyone has been working tremendously hard. It's been pretty darn good.
This is Nikki again here. I just want to add, if you guys have noticed in the chat, that survey link is there to be able to complete the survey and receive your contact hour credit for today, or half an hour, I should say. And Gareth, you already answered this too, but the slides will be available after the presentation. We are recording this, and we will work on providing captioning and post this onto our regular YouTube channel as well. So once the link to the recording is available, we'll make sure that we send that out to everybody so that you can share with those within your facilities as well.
This is Mary from Grand Itasca. I have a quick question. Can you hear me?
Yep.
Okay. Have you been seeing incidents of stroke across the board for COVID patients, or I guess I'm concerned about the younger patients that are getting COVID. It's like it's moving more toward the people in the 20s are now kind of the main numbers that are getting COVID, and are they the ones that are they having strokes after 3 weeks in the hospital as well?
I can only.
Have we seen that, Jeff?
It's a good question. I think that's a collective experience that we need more time to study. I think all we can rely on are single center or small number of small n's when they're reported, and so I haven't. I feel like our case volume in terms of ages has been about the same. But with that being said, our range is still pretty broad. So you'll see very many younger patients with strokes that are unrelated to COVID. But so I think that's a very I think we still need to learn more about that. I think what has been alarming is when places like New York and the Northeast and other places around the world that report this attention, I think, is to us aware that patients who are younger that don't have those conventional risk factors that present like stroke should be considered for stroke. But and those are great experiences to share, as I'm sure many other places around the state have seen younger patients with COVID and stroke. I just don't know what the true incidence is, and I think that requires more population-based studies to actually report that.
We still have a few minutes here for questions. So again, if you want to ask a question, please press *6 or type right into the chat. I do want to make note here real quick that Ganesh did mention community awareness of stroke signs and symptoms. We still encourage hospitals to provide community awareness of stroke signs and symptoms for your general public. We do have awareness materials available on our Minnesota Stroke website. I will make sure to include that in the follow-up email as well. But if you would like any assistance with that, please don't hesitate to reach out to us as well. All right. Well, I think with that moment of silence there, we'll probably wrap things up. Again, the survey link there is in the chat. Please make sure you fill that out. These surveys really help to shape the future webinar experiences and bring topics of interest your way. On behalf of the MDH Stroke Program and everyone on the line today, I'd like to extend our sincerest gratitude to you, Dr. Asathambi, for graciously volunteering to present today on such an important and relevant topic. So thank you. Everyone, please join us again in September for our monthly webinar. And remember to keep an eye out for that hospital inventory survey as well in the next few days here. But in the meantime, continue to take care of yourselves and each other. Thanks, everybody.